Right, hi everyone. I'm going to start my afternoon report today. My patient is a 34 years old female African-American who has a chief complaint of fever for 7 days. HPI, she is 35. She has a past medical history of SLE. She's on hydroxychloroquine for joint pains, and she was recently started on azathioprine 4 months back for the proteinuria. She presented to ED for fever of 7 days. Fever is low grade, off and on, intermittent, spiked 1 to 2 times daily, associated with chills and relieved by Tylenol. Fever was associated with the development of small lumps, swellings in bilateral armpits and sides of the neck, which developed 4 days after the onset of the fever, along with bilateral joint pain in both hands. History of sick contact, recent travel, shortness of breath, weight loss, cough, chest pain, diarrhea, abdominal pain, and recent 2 COVID tests negative in last week. Medical history is she has SLE since 2019, rash and joint pain. She has a most recent lupus flare in 3 months before the presentation, which required right knee steroid injection at that time. She also had a history of cholelithiasis. Past surgical history is significant for endometrial polypectomy. No significant family history.
I think your volume just cut out there a bit, Waqar. I'm not sure if maybe Julia can switch the camera.
Can you hear me now?
Yeah, we can hear you actually. Maybe you can continue. Maybe it was just that one blip.
Okay, might be I'm close to the mic or something. Okay. Social history regarding smoking. She has a 5-pack year smoking history. She quit smoking 10 years ago. No history of alcohol use or drug abuse. She is sexually active with 1 male partner for the last 5 years and used condoms regularly. Regarding her medication, she is on azathioprine 100 milligram daily. She is on hydroxychloroquine 200 milligram BID. Regarding allergies history, no known allergies in the past. Systemic inquiry is positive for fever, lumps and swelling in bilateral axilla and neck area. And she also noticed recently increased urinary frothing and bilateral joint pains in both hands.
At this point, is there anything else anyone would like to ask about the history before we move on to the physical? You can post in the chat if you want to know any more, I guess, about what she came in with, her lupus history, anything else that you would want to know at this time regarding her history.
She compliant with her medication, as far as we know?
Yes, she was compliant with her medications.
Any history of previous TB exposure or travel to TB endemic areas?
No history of prior TB exposure, no history of travel outside USA.
Mantej is asking if she's getting CBC checks on the azathioprine.
Yes, she was getting.
Any weight loss or night sweats from Ricardo?
No recent weight loss and no recent night sweats.
Fatima is asking when she was started on the azathioprine.
Was started on azathioprine?
When was she started?
Yes, 3 months before the presentation.
Are the nodules painful? I guess the lumps.
She doesn't have any complaint of pain in her nodules.
Any rash along with the fever, Taran's asking?
No rash.
James Prince is asking if she ever had any lupus flares before with LAD, I presume lymphedemopathy.
She never had a lupus flare with the lymphadenopathy in the past.
And Fatma's asking, did the nodules start at the same time as the fever? I think we can see here the fever is 7 days ago, and then the lump started 4 days ago.
Correct.
So I think we can move on to the physical exam.
During her physical exam and ED, she had a blood pressure of 135/77. She was tachycardic, pulse of 127. She was febrile, temperature of 102.4. It was 17, and she was saturating fine in room air. Her BMI is 2. Exam, she is a young female sitting in the bed, comfortable appearing. Have bilateral, multiple anterior cervical and left central axillary lymph nodes, palpable, variable size approximately 1 centimeter, non-tender, soft, mobile, discrete, not fixed with underlying tissue or superficial skin, and skin. The other positive finding in the physical exam was swollen bilateral proximal interphalangeal and metacarpophalangeal joints. Otherwise, no lower extremity, no rash, no discoid rash, no murmur, no rub, and no viscomegaly.
So does anyone want to try and summarize this, like 1 or 2 lines based on the history and physical to date? If you want to put back up maybe the physical exam slide to help them out, Waqar.
I can try a summary statement.
Yeah, that'd be great.
So this is a young African-American female with past medical history notable for lupus on hydroxychloroquine and newly started on azathioprine, who presents with acute intermittent fevers and joint pain and non-tender cervical and axillary lymph nodes on physical exam. Right? I don't know if I missed anything.
Yeah, exactly. And that she's febrile as well on the exam, I guess, would be the only thing as well. I think with her labs, she has the tachycardia as well. Those would be the most pertinent positives. But that was great. Thank you. Do you want to just show? So Waqar had 34-year-old female, SLE, summarizing it, saying she's on immunosuppressants, coming in with fever, and then her presenting complaints and having fever and really this generalized lymphadenopathy. So I'm just going to share my screen now, Waqar, if that's okay.
Of course.
So I guess one thing that for this patient, yes, you can see that. Having lymphadenopathy, I guess, isn't something we always see in patients coming in, and really what is meant by that. Any abnormal size of lymph nodes, abnormal consistency in lymph nodes, or abnormal number. So those are kind of the things that you're looking at, or number. And Waqar kind of touched on this already, but an important distinction to know whether or not it's localized or generalized. So localized meaning confined to one area and specific to one side. And that can really help you a lot when you're deciding, trying to figure out what might be causing it. If it's localized, you're looking at that one side and what's draining in that side and kind of focusing your history physical and your differential there. Versus if it's generalized, which for this lady it is, it's bilateral cervical and axillary, points more to something more systemic then that you need to think of, as opposed to fixating on one area. Obviously, there's a big long list of things that can cause lymphadenopathy. The most common one, or one that we frequently think of, is infection. Can anyone say, you can post in the chat what kinds of infections that you think of that cause it. So Yasmin, exactly, EBV or mono HIV, very common, like EBV, especially young people. And then you have that triad. You have fever, you have lymphadenopathy, and you have pharyngitis as well. So you'd expect to see complaints like that. And of course, you can have splenomegaly. HIV, really important. FATMA, fungal infections. What kind of fungal infections can you think of? So we have viral here. So cat scratch is actually bacterial, but yeah, definitely an important one. Especially if anyone actually has, I think it's kittens are the most likely culprit. If you have a young kitten can cause that. Any scratch will cause, can cause generalized lymphadenopathy. And then your fungals. So I see Fatima has said histoplasmosis, correct. What area in the United States do you typically associate or do you see histoplasmosis, Fatima or anyone? They always ask this in the boards for some reason, I think especially because so many fungal infections have like these distributions, but histoplasmosis is the one that you see in the Midwest, Ohio, Mississippi, is where it's most commonly seen. Any other fungal infections causing lymphadenopathy, and this another one has like a geographic location that comes up a lot, is coccidio. Yasmin, where do you see coccidio? So Southwest, yeah. So it's also called valley fever. So you see coccidio mostly in Southwest, especially in Arizona, like Eric had said. Other viruses that you can think of that would cause lymphadenopathy. I guess one way to think about it as well, because like viruses are kind of generally systemic infections. So really like so many of them or almost any of them can manifest with lymphadenopathy. So you're really kind of trying to think of common ones. So Naru says measles, definitely one to be mindful of, especially now that we have like variable uptake with vaccinations, and that you want to be mindful of and kind of being able to recognize the kind of things that you see with measles other than lymphadenopathy, like cough, runny nose, conjunctivitis. And Noor saying CMV, definitely an important one, especially like if it's like a pregnant person or like an immunocompromised patient, and we know our patient is on immunosuppressants. If it's like a young, otherwise healthy person, probably less likely to cause, serious infection. Fatima says TB, definitely important to get like a good history in terms of like where the patient's from, where did they come from, were they ever incarcerated, any exposure like that, any other infectious symptoms like cough, hemoptysis, things like that. Rubella, Naru saying, definitely. Any other like common infections that you can think of? I guess one that we see like in the primary care setting that can cause cervical lymphadenopathy, any like basic URI will cause lymphadenopathy. So especially if you're looking like at strep throat, would be a really common one that will cause like, oropharyngeal erythema, like enlarged tonsils and cervical lymphadenopathy. And that's kind of like where like it being localized can really help you and kind of pinpoint things that way. I think they're like some of the main ones. So viral, bacterial, fungal. I guess one other one that comes up a lot, like parasitic, is toxoplasmosis can cause it. More so like, especially again, like pregnant people, immunocompromised, would be important. So infection definitely can be the most common cause for lymphadenopathy. One that kind of comes up a lot as well, or I guess things that sometimes people can jump to, is malignancy. What kind of things do you think of cancer related causing lymphadenopathy? So what kind of diagnosis? Yeah, lymphoma. So cancer of the lymph nodes, definitely. So any lymphomas, leukemias as well, depending on how the type or how extensive can cause it. And any mets, yeah, exactly, Ricardo. So any metastatic disease can cause it. And really like the location is going to help you a lot, right? So If someone has like head and neck cancer, is coming with like hoarseness, change in their voice, and you have cervical lymphadenopathy, obviously that, and they have like other risk factors like smoking history, that's going to make you really concerned. Or like breast cancer with axillary lymphadenopathy, having those kinds of associations, or inguinal lymphadenopathy, any like GU cancers that you need to be aware of. So I think really any met that you can think of, and kind of associating it with that area. If you're looking at the history and physical of a patient, what things on the history and physical would make you more suspicious of a malignancy or as a cancer causing the lymphadenopathy? What things on the patient's history or even on the exam would make you think of it? So Maria's saying B symptoms for sure. So like any constitutional symptoms like that, like if you have drenching night sweats, you have like weight loss, like more than 10% weight loss in 6 months, and would make you concerned for a malignancy or like a lymphoma. Non-tender, Yasmin saying, that's actually quite an interesting one. I think like the tenderness is related to like the lymph node capsule stretching. So you often, if there's an infection, inflammation that causes stretching of the lymph node, that will make it painful. So you do think more likely like infection, but if you have like an aggressively growing cancer, that can stretch it quickly too. So actually non-tender isn't 100% useful all of the time, because depending on the malignancy you're dealing with, you can see it as well. So Eric is saying age for sure. So age greater than 40 is a useful cutoff. Above age 40, it's more likely, or you have a higher chance of it being associated with malignancy. So that's kind of a cutoff that they use. Smoking history, weight loss, history of cancer, exactly, Matt. So if they have any history of cancer, like recurrence or mets, can manifest as lymphadenopathy. Not Midwest. Sorry, Dr. A. My US geography isn't that great. I was going through it with Sananda earlier.
No worries.
So we'll say Ohio, Mississippi, Missouri is not Midwest. Other things that would make you, on the physical exam, that would make you think lymphadenopathy could be malignancy. So I know Waqar did like a really nice detailed history describing the lymph nodes. What things would you be looking on physical exam that would make you concerned? So if it's generalized, yeah, I think if it's generalized, it just tells you that it's systemic. It's not necessarily telling you much more beyond that, but it will point towards something being systemic. So hard for sure. Matted is a good one. So I guess this cells overgrowing on top of each other. If it's fixed or immobile, like Maria had said, would be concerning for sure. If it's freely mobile versus fixed, would be a huge difference. So fixed more likely to be malignant for sure. And I think those were the main things. The weight loss was said as well. The size, yes, how quickly it's growing. And the other things that come up a lot is timing. So something, and I think this is kind of what they use as like a cutoff sometimes for how often to, like when to do a biopsy or things like that. So if something's been there for less than 2 weeks, it's less concerning for malignancy and more suggestive of something that might be reactive, versus if something is there for more than 4 to 6 weeks, can be more concerning that it's not like an acute infection that has passed. Other things that come up is like the type of node sometimes. So I know our patient has cervical axillary lymphadenopathy, but I think one that I remember a lot from med school and the supraclavicular node. So that's because of the sites it drains. So it drains the GI and the thorax. If you have lymphadenopathy in a supraclavicular node, that's more likely to be malignant. It has a much higher probability. So it's generally not normal or not reassuring to see enlarged supraclavicular node. And I think those were the main ones that would be malignancy related. Obviously, the other group that's important. So we did infection, malignancy, which I think cover a lot of those. For our patient, obviously, autoimmune or like a collagen vascular disease would be important. So I can start, obviously, SLE can be a cause of lymphadenopathy. It's actually not part of the like diagnostic criteria, but if it's present, can be suggestive. What other like rheumatologic conditions do you think of that can cause lymphadenopathy? So Rebecca, Sjogren's for sure. Other rheum conditions that you need to think of? Not just like related to our patients. So sarcoidosis, I guess, doesn't like 100% fit in there, but definitely a cause of like hilar lymphadenopathy, juvenile RA, or even regular RA for our patient. Those would definitely be the main ones to think of. And then another group that I wasn't like too familiar with as a cause can be medications actually causing it. So a lot of medications either like causing like DRESS syndrome, like the drug rash with eosinophils and systemic symptoms, or just by themselves can cause lymphadenopathy. And it's the same kind of medications that are like implicated in other kind of hypersensitivity reactions. So like your anti-epileptics, like phenytoin can be one of them. Antimicrobials, Bactrim, I think can be one of them. And allopurinol as well actually is one. The medications our patient is on would not really be associated with it. So hydroxychloroquine, azathioprine, not really implicated, but I thought that was kind of an interesting subgroup of causes of lymphadenopathy that we don't always think of, seeing what medications the patient's on or medications that they have been on before. So I guess this is kind of going over like generalized causes of lymphadenopathy, kind of, I guess, pulling it back to our patient, like a young African-American lady with lupus, on immunosuppressions, coming in with fever and this cervical axillary lymphadenopathy. I guess the things here, based on kind of everything we've discussed, that seem most likely, obviously infection because of the duration of her symptoms, everything has been a week or less. Obviously infection would definitely be there, and she's technically immunosuppressed. So you kind of have like a large amount of infections that could be implicated. Malignancy, like we talked about, maybe less so, based on her history, based on the physical exam findings, based on the duration of symptoms, her age, definitely seems less likely. And obviously she has a history of SLE. It doesn't seem like this has been kind of the way her lupus has manifested in the past. But obviously the lupus being the cause or a flare of lupus would be hugely concerning. So if you had this patient in the emergency department, you admit this patient, what would be your initial investigations or things you would look in? And based on kind of the things we've talked about so far, feel free to post in the chat. So what labs are you going to order? So Yasmin, CBC for sure. So that can help with like a couple of things, looking if there's any infection, if you see an elevated white count, or even like with a lupus flare, if you have any cytopenias that might be implicated. A UA can be useful as well. She has proteinuria, is on azathioprine for that. So you want to look at that as well, especially seeing if there's any protein. And then, yeah, so Matt's touched on the labs that we talked about are the infections that you would be concerned about. So Hep B, Hep C, HIV. Vincent is definitely our rheumatology specialist. He knows all of the SLE flare labs. So your double-stranded DNA, C3, C4, and protein, for sure, because this would be concerning for this patient that this is a flare of her disease. And spot urine protein. Pregnancy test, yes, I'm glad you said that. Especially this is a woman of like childbearing age. and medications that she's on and treatments that you maybe want to do. That's something you want to know for sure. Teresia said viral serologies. Which viral serologies were you referring to? I know we've added in, so CMV, EBV. So I think doing a monospot would be reasonable. CMV, you could do CMV serology, might not always be that helpful. Doing like CMV, IgM, IgG, depending on the patient, because it can be quite common anyway. But this is immunocompromised patient. Yeah, and a chest x-ray. I'm not sure we would jump straight to a CT chest, but I think a chest x-ray could give us a lot of information. Like if there's any concern for infection there, if you're concerned for any like other adenopathy anywhere else. Peripheral smear could be helpful too. What were you thinking with that, Matt? Or what things would you see on a peripheral smear?
I mean, if you were worried about like an acute leukemia or something like that, you might do that. I mean, it's fairly low cost and easy to do. So I think we probably don't do it enough, just generally.
Yeah, so I think if you're like concerned for malignancy, things like that, that would be for sure. Autoimmune hemolytic anemia, yeah, for sure. So if you're kind of, depending on what our CBC shows us, then you could go down the route of like a more extensive workup for that, your LDH, your aptoglobin, but you'd want to see what the CBC and your diff shows first. So I think this is a reasonable place to start, getting some basic labs for our patient, kind of focus on the things that we're most concerned about, because we want to see CBC, and we want to really see all of the lines in this patient related to infection, related to the lupus, if it's affected the counts, ruling out the viral illnesses that could be most commonly associated with lymphadenopathy and that we for sure don't want to miss. And also being aware and being mindful of like her lupus, which seems to be obviously causing her lots of problems, like with medications, that changes that she's been on, and proteinuria that she's had. For sure having a pregnancy test as well before you're going any further with any like further testing or treatments you may give that may interfere with that. So if you want to start sharing your screen, Waqar, to kind of go through what actually happened to this patient.
Okay.
Yeah, looks good.
Starting with investigations, CBC. She has a bicytopenia, white cell count was 3.7. Differentials were 8.2. Her baseline hemoglobin was around 9. MCV was fine. No thrombocytopenia. I was saying in the chat, they asked for check the lactate. Lactate was fine too. Albumin was 2.8. ESR was 112. CRP was 5.52. LDH was raised 633. She was found to have positive direct Coombs test IgG. Haptoglobin though normal. Low C3 and C4. And her DSDNA was inactive. Importantly, prior immunological workup 6 months back, she was having the ANA positive in a high ratio speckle. She has positive anti-Smith antibodies, SSA, SSB, and positive RNP antibodies. She had a negative DSD and DSDNA, and her urine protein creatinine ratio random was 1.2 gram per gram of creatinine at that time. Starting her infectious workup, her CMV PCR is negative, HIV 1 and 2 antibodies negative, monospot for EBV is negative, Hep B surface antigen negative, HCV antibody negative. Her urine test, her UA showed protein of more than 500, however, no blood. Her urine protein creatinine ratio random showed 2.5 gram per gram of creatinine, which is raised from 1.2 6 months back. Her urine pregnancy test is negative. was her EKG. Significant in her case. And that was her chest X-ray, showing some increased cardiac cell width, but there's no hilar lymphadenopathy. Our final diagnosis in her case was most likely lupus flare based on fever, generalized lymphadenopathy, erased ESR, all that stuff. Talk about her course. We started her on the oral prednisone. We did antibiotics. Oral prednisone was 1 milligram per kg. And after 4 days of hospital stay, the fever subsided, her lymphadenopathy improved, arthralgia resolved, and her hemoglobin also improved from 8.4 to 9.2. Was discharged with the oral prednisone. Was also consulted who planned with an outpatient renal biopsy, which showed membranous nephropathy class 5, and she started with the mycophenolate. And her repeat urine protein creatinine ratio random after 1 month of mycophenolate showed only 190 milligram per gram of creatinine. Questions here?
And were rheumatology consulted like pretty early on for this patient?
Yes.
I have one question. Did you consider stopping her azathioprine in this situation?
Was not sure that why she was started on the azathioprine. Based the history she gave, that she said that she was losing some protein, and that's why she started on the azathioprine. She was never seen by a nephrologist as an outpatient. Azathioprine is definitely not a choice in a person who has lupus nephritis. Mycophenolate is the first choice here. Right. So brief discussion already Jackie has discussed in large details and almost dissected every aspect of lymphadenopathy. I'm going to quickly tell you lymphadenopathy. We have different groups, or we can say the areas like submandibular, submental, preauricular, cervical, supraclavicular, infraclavicular, axillary, inguinal, popliteal, and epitrochlear. Might be this is it's worth mentioning here: epitrochlear lymph nodes and the popliteal lymph nodes. When we define the lymphadenopathy simply is an increased in size or swollen lymph nodes. And what is the cutoff of the size of the lymphadenopathy? In general, it's 1 centimeter or 10 millimeter. If the lymph node is more than bigger than that in any group, we usually say it's a lymphadenopathy. But if it's more than 0.5 mm, 0.5 centimeter or 5 mm in epitrochlear lymph node group, it's pathological. For the inguinal lymphadenopathy, we say it's if the lymph node size is more than 2 centimeters, then it's pathological. If it's less than that, less likely it's pathological. And if we talk about the axillary lymph nodes, especially, there are 5 groups we need to know. There are anterior axillary lymph node group, posterior, central, lateral, and apical. So talking about further lymphadenopathy, when we don't have any known reason for the lymphadenopathy, we classify lymphadenopathy as a localized or generalized. Localized lymphadenopathy is usually in 75% of the cases, and this is usually when the local is involved. Either it's because of some infection over there, or it could be malignancy. When we say the generalized lymphadenopathy, it's usually in 25% of the cases. To define the generalized lymphadenopathy, the lymph nodes should be enlarged in 2 or more non-contiguous areas. it should be lymph node group. Like if you have an axillary lymph node group and then the cervical lymph node group and then the contralateral cervical lymph node group. Now these three lymph node groups have been involved, then you can say, okay, this is the generalized lymphadenopathy. But if you have anterior cervical lymph nodes and posterior auricular lymph nodes on the same side, only two lymph nodes group, but they are like they are contiguous, you cannot say it's a generalized lymphadenopathy. Once the lymph node is palpable, the most important thing is the comprehensive examination. You need to tell how many numbers of the lymph nodes has been involved, what group of lymph nodes are involved, what is the size of the lymph node, what is the consistency, either they are tender or not tender, either they are matted, they are combined together, or they're discrete, they are mobile, or they're fixed. And how about the overlying skin? Is there any sinus draining? Are there any signs of infection there? So as we discussed, size usually is a 1 centimeter. For the inguinal, if it's inguinal, if it's more than 2 centimeter, and for the epitrochlear, it should be more than 0.5 centimeter. Pain, tenderness, the tender lymphadenopathy tells you that this is most likely inflammation or infection, because when the size increases quickly, the capsule stretches and causes the pain. The consistency is important. If it's soft in consistency, it's most likely infectious and the inflammation. But if it's a stony hard, it's most likely cancer or metastatic cancer. And for the lymphomas, it's in between, like firm, rubbery consistency signifies a lymphoma, a lymphoproliferative disorder. If the lymph node is discrete or it's a lymph node is a matted. How will you say the matted lymph node? If it's a group of the lymph nodes which feels like all the lymph nodes are connected each other and we try to move, they move like in a unit. Very, very, very likely that the patient might be having the tuberculosis, malignancy, or the sarcoidosis. Then the fixation, you have to feel the lymph nodes, either they are free from the underlying surface, they are freely mobile, or they're fixed. If they're fixed to the underlying surface or they're fixed to the overlying skin, it is likely suggestive of the invading malignancy, which is causing that. And then the skin sinus or skin ulcers, if there is a skin sinus or an ulcer, it's likely to be some infection, but if there is a tethering of the skin, it's likely the malignancy. Then again, location and the site, it's very important. And if we combine the location, site, the physical exam findings, the history and the physical and the history, everything, you will come up with some kind of a diagnosis and a differential diagnosis. Like in cat scratch, some scratches, history of cat at home, an ipsilateral, cervical, or the axillary lymphadenopathy, cat scratch, sore throat, splenomegaly, fever, cervical lymphadenopathy, infectious mononucleosis, tonsillar exudates, tender cervical lymphadenopathy, fever, strep infection, inguinal lymphadenopathies gives you some clue, okay, and rough sexual behaviors, could be HSV infection, secondary syphilis, or could be chlamydia, lymphogranuloma venereum. And this is the most important, the supraclavicular lymphadenopathy. Whenever you have a supraclavicular lymphadenopathy, this is highly likely the patient do have some malignancy underlying. Right supraclavicular lymph nodes drain the mediastinum, lungs, because like the structures from the chest. And if you have a right-sided supraclavicular lymphadenopathy, think about lung cancer, mediastinal and the esophageal cancer. And if you have a left-sided supraclavicular lymphadenopathy, these lymph nodes, they drain the lymphatic flow from the thorax and the abdomen. We know the Virtue's node from the stomach, and also the Joseph-Mary nodules from the stomach malignancy. Left-sided supraclavicular malignancy, likely intra-abdominal. And this is the location, different groups. Let's talk about individual group. It's a pre-auricular lymph nodes. It drains the scalp area from here, the skin, and the lymphadenopathy here can signify the local skin infection. It could be a lymphoma, it could be a leukemia, squamous cell cancer of head and neck, Same, cervical, anterior cervical lymphadenopathy, submandibular, and posterior cervical lymphadenopathy. They can have a lymphadenopathy in case of lymphomas and leukemias and the local infections. Same here, and inguinal lymphadenopathy, sexually transmitted diseases, scrotal cancers, local infections there can cause. But we are more concerned with the generalized lymphadenopathy, and as that my case was. When you have a generalized lymphadenopathy, you need to be more focused on the systemic signs, especially on the examination. Look for the rash, look for the mucous membrane lesions, look for the arthritis to rule out the autoimmune processes. Look for the hepatosplenomegaly, which could be myeloproliferative, lymphoproliferative disorders, and also lupus can also present with the splenomegaly. And the bony tenderness, especially the bony tenderness with the combination of splenomegaly and the lymphadenopathy gives you clue of the lymphoma or the leukemia underlying causing that. So again, if we talk about the details causes of generalized lymphadenopathy, first is the hematological malignancies, lymphoproliferative disorders, leukemias, lymphoma. Sarcoma can present with the generalized lymphadenopathy, and metastatic cancer can cause generalized lymphadenopathy. Infection we discussed in the details, virus, bacteria, fungal and protozoal. Rheumatological, rheumatoid arthritis, SLE, in my case, Still's disease, mixed connective tissue disorder versus host disease, sarcoidosis and other vasculitises can present with the generalized. Generalized lymphadenopathy can be because of drug-induced allopurinol, phenytoin, carbamazepine, and the drug reaction, serum sickness, or DRESS syndrome, which is like eosinophilia with some rash, facial edema, arthralgias. You can have generalized lymphadenopathy in such cases as well. So how would you generally approach in a person who comes with the lymphadenopathy? Talk about the lymphadenopathy, not the generalized or a solitary or one group of the lymphadenopathy. Whenever you have a lymphadenopathy, you don't have any other clue in the history. Go for the history, go for the physical exam. If you don't have any other clue, think what you have to do further now. If it's unexplained, if you don't have any clue, then first try to rule out whether the patient is having a high risk of malignancy, like type B symptoms, weight loss, and these kind of features. If you do have, then I think go straight away for the biopsy. If the patient is having a low risk and you don't have any clue for the infection and autoimmune process or anything, then see if the patient has a generalized lymphadenopathy or regional lymphadenopathy. If patient has a generalized lymphadenopathy, then you need to do this, at least some workup with the CBC, syphilis, HIV, Hep C, and the autoimmune workup, ANA, and these kind of a testing to see the generalized lymphadenopathy workup. But if the person has the regional or solitary lymphadenopathy, and you have ruled out the patient has a low risk for the malignancy and know the possible causes, then wait, observe for at least 1 month and see if the lymphadenopathy is resolved. If it's not resolved, then check again if it's persistent or changing lymphadenopathy. In that case, it's better to go for the biopsy.
Thank you so much, Waqar. After the patient finished the prednisone, was it hydroxychloroquine and mycophenolate? That's what the patient was sent home on?
Yes, patient was sent home on prednisone and hydroxychloroquine. Once he had the biopsy, she was found to have membranous nephropathy. Then she was started on the mycophenolate.
Any other final questions or comments from anyone? Thank you so much, Waqar, for a great case.